Hi. So I'm an intensive care trainee. I'm currently based up the road at the paediatric intensive care unit at Lady Salento Hospital in Brisbane, having initially trained as a paediatrician. So I gained a little interest in the human aspects of healthcare system performance while studying towards a Masters of Public Health, and currently with the support of the Practice and Economics Committee, I'm undertaking a project looking into the rate of burnout among intensivists in Australia and New Zealand, and of some of the organisational or workplace factors that may be associated in this setting. So this morning I'm going to speak specifically about burnout, and in particular burnout among doctors in intensive care. So if there are people from other disciplines in the audience, I apologise for the medico-centric themes of this presentation. I plan to speak very briefly about what burnout means and what its impact on the medical workforce, on the individual clinician, on the patients that we look after. In the last 5 or so years, there seems to have been an increase in both the medical literature and in mainstream media in discussion on the perilous state of healthcare professionals' mental health and well-being. Burnout is just one of several related concepts that are tied up together under the banner of physician welfare. The concept of burnout, however, is not new. The term has long been used to describe those who have become worn down and disinterested after being exposed to persistent and pervasive emotional stresses and frustrations. It's seemingly a phenomenon of the 20th and 21st centuries. However, some authors consider the 19th century malady of neurasthenia as an early description synonymous with burnout. It's now regarded as a syndrome specifically related to work, and it's thought to develop as a consequence of chronic workplace stresses. It was first described in the occupational psychology literature of the 1970s as a syndrome noted in those whose work is concerned with helping people. It's now recognised, however, that the phenomenon of burnout is not limited to those whose professions are involved with contact with people, but is experienced in any number of occupational settings. In the context of helping type professions such as medicine, nursing, social work and teaching, burnout's related to the concepts of compassion satisfaction and compassion fatigue. Compassion satisfaction refers to the pleasure that you derive from being able to do your work well. Perhaps this is the why in the golden circle referenced in the earlier talk. Compassion fatigue encompasses burnout and also this other construct of secondary traumatic stress, which is not thought to be common but does have an impact on the employee's ability to function effectively in the workplace, especially in a workplace like intensive care. Burnout itself is described as having 3 components: emotional exhaustion, depersonalisation or cynicism towards one's work, and a diminished sense of personal accomplishment or professional efficacy. Emotional exhaustion is considered a core feature of burnout. Depersonalisation or cynicism towards one's work, it's related to, clinicians will often describe developing emotional distance or a detached concern for their patients and families as a way of protecting themselves. But this concept of depersonalisation takes this a bit further and is considered a more callous or negative extension of this. And the third aspect is that of a reduced sense of personal accomplishment or professional efficacy, which refers to a lack of achievement and productivity at work. This might simply be as a result of the other 2 components, the difficulty being in feeling accomplished whilst simultaneously feeling emotionally exhausted and detached from one's work. So why does this matter? Those that experience burnout may feel frustration, anger or moral distress and be disillusioned and cynical regarding their work and the people they work to help. So it's hardly surprising that health professionals' experience of burnout has been described as having significant impact on both their personal and professional lives. Burnout is associated with increased incidents of depression and anxiety, self-reported measures of personal distress, increased use of alcohol and drugs, and relationship and family problems. From a workforce perspective, it's also been associated, or a workplace perspective, it's also been associated with measures of suboptimal patient care, medical practitioners' incidents of self-perceived major medical errors, and by its own definition is associated with decreased productivity and professional effort. It's recognised as a factor in increased job turnover and absenteeism. Who's at risk of burnout? Last year in the US, the Critical Care Society Collaborative published simultaneously in 3 different journals a call to action regarding burnout syndrome in critical care health professionals. This was in the context of increasing concerns about the changing face of healthcare provision in the US, which is a completely different environment, as has been alluded to in previous talks. Much of the commentary specific to the critical care setting makes reference to the results of an American physician's lifestyle survey published in 2016, which places critical care physicians at the top of a ranking of those with the highest rates of burnout. This survey reported that more than 50% of US critical care physicians meet the classification of being burnt out. Fortunately, in other settings, the figures, while still significant, are not quite as grim as this. In 2013, Beyond Blue reported a national survey on the mental health of doctors and medical students, and reported rates ranging between 15 and 35% of high scorers in those 3 domains of burnout. In 2016, the Australasian College of Emergency Medicine Workforce Sustainability Survey reported between 20 and 40% of respondents scoring highly in these areas. A study of New Zealand hospital-based physicians reported similar figures, published in 2009. And 10 years ago, almost to the day, a survey of Australian intensivists was conducted, and this paper reported 42% of respondents showing signs of emotional exhaustion, 32% scoring highly in the realm of cynicism, and 37% showed a low degree of personal accomplishment. So, what can be done? There's countless resources that exist that counsel on measures that the individual can take to protect against burnout. Exercise, time spent with family and friends, mindfulness practice, resilience training. They're all sound practices that have the backing of evidence to support their role in decreasing burnout. However, placing the onus on the individual is likely to be ineffective without the engagement of the organisation and acknowledgement of the environmental and cultural factors within the work unit and the greater intensive care community that influence the development of burnout. The soon-to-be-released Burnout survey aims to determine some of these workplace factors. By improving our understanding of these variables in the Australasian context, we may be able to develop further strategies and interventions to prevent the development of burnout and to assist intensive care doctors who are currently already experiencing features of burnout, which is where I hope you all come into it. In order for the information we collect to be meaningful and to have an impact on how the needs of our workforce are advocated for in the future, it needs to accurately reflect the current state of play. And so I'll hope that those of you here that meet the eligibility will be on the lookout for your surveys and will not only complete and return them, but go back to your units and encourage others to do so too. Thank you.